Good day, everybody. Our talk today will be about ethics in obstetrics and gynecology, ethical issues in obstetrics and gynecology. We are going to do it into two parts, selecting certain obstetric and gynecological problems and see the ethical issues and how to solve them in that. The content of our talk today will be about generally the principle of ethics, and I'm sure you had that in your introduction. Are going to talk about abortion, talk about sex selection antenatally, the abortion laws, the ethical framework for the gynecological and obstetric care. We'll review the stereotyping thinking about women, what most everybody think women are. Then we'll talk briefly about cesarean section on demand, which is becoming an issue now. So generally the principles of ethics known to you for autonomy, beneficence, non-maleficence, and justice. That's in every part, whether that is professionally, whether that is bioethics, whether that is research ethics, the four principles are there. What do we mean by autonomy? Autonomy, the self-rule that is free from both controlling interference by others and from certain limitations, such as an inadequate understanding that prevents meaningful choice. That's to say, the lady has to have full information and she is the one who had to make her choice. That's the autonomy. The beneficence, providing benefits to others, and principle of beneficence, moral obligation, protect and defend rights of others, help people with disabilities, non-maleficence, excuse me, an obligation not inflict harm on others. As a physician or a doctor, your job is non-maleficence, that is not inflicting any so what it means, first, do no harm. It should be distinct from beneficence. Beneficence, as we have said, is to do good, as the principle of ethics. Non-maleficence, briefly, do not inflict any harm. So the distinction between the two, obligations not to harm in non-maleficence, obligations to help others, rescue or drowning child, withholding and withdrawing self-sustaining treatment, intended effects and merely foreseen effects. So these are obligations you have to do to help others and to do no harm. The justice, fair and just distribution of social burdens, benefits, opportunities, and allocation of positions. That's to say, if you are using a human being for a research, then there should be justice in that he or she will have benefit being distributed equally, the burdens being distributed, and also the allocation of positions if you are in a situation where you can make decisions for allocation and distribution of facilities that include access to health care, selection of for research subject population. So, having mentioned that briefly, autonomy, beneficence, non-maleficence, and justice or just, then we go into application of these issues into our obstetric practice. So I'll give you a case of a scenario which you may see while you are starting your work or during your career as an obstetrician and gynecologist. The scenario states that if 18-year-old unmarried student at one of the universities, brought by her mother for irregularity of the menstrual periods for the last 2 years, according to her or to F. F noted a mild dysuria and increased frequency of micturition. She was otherwise healthy and good at her studies. She was referred to the gynecologist by a physician who examined her and found no abnormality which he can manage. So he referred her to the gynecologist. The gynecologist, after detailed history, the gynecologist performed an abdominal and pelvic ultrasound that showed a live intrauterine fetus of about 14 weeks gestation, yet F denied having any sexual relation with anybody. She denied that. The gynecologist, it is his duty to inform the mother. The mother, being informed about that, she asked for a termination of the pregnancy and to keep everything secret between the three of them, the mother, F, and the doctor. That's because for fear of the male side of the family and family stigmatization. So here, a lady or a young girl who illegally conceived, she knew that family does not, came to the doctor and they asked for an abortion. So let me give you a few words about abortion, what it means. We talk about miscarriage, stillbirth, and abortion to differentiate between them. Miscarriage is a spontaneous loss of a pregnancy from conception to 20 weeks gestation. Some people go to 24 weeks. That is the miscarriage. The key word is spontaneous. If it died after 20 weeks or after 24 weeks, it will be a stillbirth. Abortion differs that it is a deliberate termination of a human pregnancy using drugs or surgical intervention after implantation and before the fetus is independently viable. Viability ranges between 20 to 28 weeks. Used to be 28 weeks, came down to 24 weeks, and now some centers up to 20 weeks. That is to say, if the fetus is born at 20 weeks, probably the facilities are available to make him survive this preterm death. So this is abortion. We are going to talk about the last part, which is the deliberate termination. So, personhood. We are dealing in obstetrics with the two patients, the mother and the fetus or the child in her uterus. We have to be caring for both. So, is he a person to be considered less than 20 weeks? Here we go to Al-Quran Al-Kareem. الآيات بتقول ولقد خلقنا الإنسان من سلالة من طين ثم جعلناه نطفة في قرار مكين ثم خلقنا النطفة علقة فخلقنا العلقة مضغة فخلقنا المضغة عظاما فكسونا العظام لحمة ثم أنشأناه خلقا آخر فتبارك الله أحسن الخالقين. This is the verses in the Quran which describe the embryological development after fertilization very precisely. This is the translation of it in English. Ayazata. So, shall we consider the fetus in utero a person, and thus he has all the facilities of personhood? We should not injure him or her. Every right to life, every human being has an inherent right to life. Being born, you have the right to live and live your life the way it goes. The fertilized ovum has within it all components needed for the growth and development into full person. Once it being fertilized, it just goes through the stages described earlier on, and eventually he could be developed and will be a full person. So when does a developing embryo become a person? And we treat him or her as a person, not as an it or an embryo. Is it from the moment of conception or implantation, the time of fertilization, and then implantation in the uterus? We consider him as a person. He had the right for life. Is it from when the fetus is viable and capable of independent existence if removed from the milieu of the uterus, that's say after 20 weeks, or when the brain starts developing, drawing the analogy of brain death? So here we are looking at the brain active or not. So at what stage shall we consider this as a person? If you do an ultrasound on a pregnancy at about 6 weeks, you will see the fetal heart. Okay? And you can see fetal movement. But when we talk about the ruh, the soul, when does it come into it? Fetal heart at 6 weeks, we can see it. We don't know ruh at that time there or not. Quran say, وَيَسْأَلُونَكَ عَنِ الرُّوحِ قُلُ الرُّوحُ مِنْ أَمْرِ رَبِّي وَمَا أُوتِيتُم مِنَ الْعِلْمِ إِلَّا قَلِيلًا. We don't know. الحديث بيقول أنه probably at 120 days. الحديث في صحيح البخاري إن أحدكم يجمع خلقه في بطن أمه 40 يوما ثم يكون علقة مثل ذلك ثم يكون مضغة مثل ذلك ثم يبعث الله ملكا فيؤمر ب4 كلمات ويقال له اكتب عمله ورزقه وأجله وشقي أو سعيد ثم ينفخ فيه الروح. صحيح البخاري جزء 4 حديث 549. So here probably in 120 days there will be a soul or a ruh. This is the English translation of al-hadith. So here we are dealing, is it a person or not? If it is a person, has it got a soul or not? These are two ethical issues. We should consider them. And accordingly, you decide whether to do abortion or not. Generally, performing abortion, that's to say, actively inducing it, has certain situations which are acceptable ethically. Others are not. It's not on demand. So indications for abortion in general, to save the life of the mother. The mother has a disease, you would like to save her mother. Here, ethically or religiously, you are allowed to perform an abortion to preserve the physical and mental health of the mother. This is an indication which is put in the Western world. For us as Muslims, it doesn't work very well. We don't accept it, frankly. In cases of rape and incest, acceptable. When the unborn child has birth defects incompatible with life, you diagnose some congenital abnormalities incompatible with life, then in that situation, abortion could be indicated and performed. Fetal reduction. Briefly, what fetal reduction means in assisted reproductive technology, or just to make it easier for you, test tube babies performed in the laboratory, fertilization of the ovum by sperm in the laboratory, and then after it's being fertilized, will be put back into the uterus and the pregnancy will continue. We call it in vitro fertilization plus ET, which is embryo transfer, IVF. So in such situations, sometimes the physicians or the gynecologist may put too many eggs or too many fertilized embryos, 3, 4, 5. Obviously, if that happened and all of them got implanted, then that will cause problem to the mother, as we will see in a minute. So in that situation, fetal reduction or abortion is possible. You leave some of them and you get rid of the others. Certain techniques are known how to do that. For social and or economic reasons, that's if the mother cannot afford to support a child. I'm talking generally here. In Islam, this is not accepted at all. Yes. وَفِي السَّمَاءِ رِزْقُكُمْ وَمَا تُوعَدُونَ. And you go to other places, Western world, probably they may take it for that. And on demand. And if you're just hearing now in the Western world, especially in the States now, people are talking about abortion as an issue, as a political issue. The new president thinks that it should not be done. Other groups of people feel that it is the woman's right. If she doesn't want to carry this pregnancy, she has the right. That's as far as they are concerned. On demand, not acceptable in Islam. It's not there. So just to summarize what we can do in our country, save the life of the mother, case of rape, when the unborn child has an abnormality which is incompatible with life, and for fetal reduction. So termination of pregnancy for maternal conditions, ethically justified when undertaken for medical reasons to protect the life or health of the mother. Just to say, if it is a molar pregnancy, it is a pregnancy. We terminate it. We know there may not be a fetus there. All is trophoblastic tissue. But we have to terminate that. In an ectopic pregnancy, in a way that is some sort of termination of a pregnancy, because we know it's going to cause problem to the lady. In case of malignant diseases, most people will also consider it to be justified in what we have just mentioned. Rape or incest, severely malformed fetuses, or when the mother's life is threatened by other serious diseases, not by the pregnancy, and the other problems, threaten her life. So in such a situation, it is justifiable, ethically acceptable from the Islamic scholars have put fatwas to say that is acceptable and to be approved in such situations. So let us talk about abortion in general. Some oppose abortion and some go for abortion. Those who oppose abortion believe that the argument is Fetus has to be regarded as a human being. Early on, we talked about personhood and the soul. So any fetus, they believe, has to be regarded as a human being, because eventually it will be. If it's killing an innocent human being is morally wrong. Abortion means you are going to kill it. Abortion is an example of killing and terminating a human being's life. So being engaged in abortion is morally wrong. Extreme opponents of abortion argue that abortion is equivalent to murder, as if you have killed somebody, and that no matter how much women may suffer, they cannot be allowed to kill their children. This is the general populace of the world. Some oppose abortion as an issue, not to be done for the following reasons. Proponents, those who argue for abortion, they want abortion. Their judgment or their arguments are: a person is not under obligation to conceive children if it would be harmful to her life or stop her achieving other worthwhile things. Having an unwanted child can have a massively detrimental effect on the lives of its parents and siblings. Some women organizations emphasize that a woman has a fundamental right to decide for herself as to whether pregnancy should be terminated or not. So you can see their arguments here, which are not very much acceptable from a lot of people. And let us concentrate on what we do in our country or the world or the Islamic world we work on. Abortion is allowed, justified, permissible in the situation we have mentioned. Others are not there. Congenital anomaly, if it occurs, is an indication, as we have said. Congenital abnormality of a structure, function, or body metabolism that is present at birth and result in physical or mental disability, or it is fatal. So any abnormality that have these problems, physical or mental disability, or is fatal, whether it is a structure, function, or metabolism, we call it congenital abnormalities, and it is grouped under four categories, major categories: congenital heart diseases, orofacial clefts, Down syndrome, neural tube defects. These are all congenital anomalies. Some of them would not reach the stage whereby you could justify abortion for that. Others, yes. And that is where the treating gynecologist with another person or the group of gynecologists decide that this anomaly or congenital abnormality is incompatible with life or is going to cause physical or mental disability or is fatal. Then by then they decide to terminate the pregnancy. Otherwise, it could carry on. Methods of prenatal diagnosis are there. That's to say, you can diagnose an anomaly by the following methods while the fetus is in utero. Pre-implantation genetic diagnosis, that's in cases of IVF clinics, assisted reproductive technology, whereby they fertilize the ovum by the sperm in the laboratory, and then before putting back into the uterus, they make genetic diagnosis. And the importance of this genetic diagnosis is to decide if it's a boy or a girl. And consequently or subsequently, there are certain sex-linked diseases. So we try and avoid the sex to which the disease is linked to be put into the uterus. We put the healthy one. Fetal DNA screening in maternal blood, we can then know. whether this is a boy or a girl. Chorionic villus sampling, serum biochemical screening, test for Down syndrome or neural tube defect. All these are available. You will know them in due course of your gynecology. Amniocentesis, chordocentesis. Amniocentesis, taking the amniotic fluid, ultrasound guided, and then you test for it. Chordocentesis, you take from the cord. Ultrasound, 2D, 3D at 18 to 20 weeks may tell you this the sex of, tell you the sex of the child, and accordingly, has it got any disease linked with it or not. Ultrasonography with Doppler. So all these are available methods now we can use, and we can diagnose a child in utero, and we will have a good idea whether that child is going to have a congenital abnormality incompatible with life or not, according to the sex it has. And accordingly, you will decide. So this is in general a brief abortion, when to do it, situations, when to consider the fetus as a person, and then how to perform it technically, no problem. We are talking about the ethical issues now. So abortion laws is a legislation and common law, prohibits, restricts, or otherwise regulate the availability of abortion. The definition of abortion law, there are abortion laws worldwide. In country X, it is permissible. Country Y is forbidden. Country G, for example, permissible for certain diseases. So that is the law according for abortion in that particular country. And we will see the changes that have taken place into it. It has been a controversial subject in many societies through history, whether to do abortion or not, to regulate it, to prohibit it, to permit it, to allow it. A controversial subject on religious grounds, moral grounds, ethical, practical, and now being in political grounds. So the law is controversial, varies from one country to the other. For example, in the United Kingdom, it is legal up to 24 weeks under the Abortion Act of 1967. However, if there is substantial risk to the woman's life or fetal abnormalities, there is no time limit. So it is permissible in the UK. By the early 20th century, many countries had begun to liberalize abortion laws, at least when performed to protect the life of the woman, and in some cases, on women's request. In some parts of the world, some countries, it is a request. She comes and she wants an abortion, she has the right to do it according to the law of that particular country. We take examples. Soviet Union, Vladimir Lenin legalized abortion or request as early as 1920. Then the one who came after him, Joseph Stalin, restricted this only to medically recommended cases. So this is political things here, not only religious, this is political. He restricted abortion only when it is medically recommended. And the reason for his restriction is to increase the population growth. He wants the Soviet Union to be more popular. And that's in 1936. So these are one country giving you an example of it. These are other countries which we have, they have now permission or law permits or otherwise. 1930s, several countries, example we give here, Poland, Turkey, Denmark, Sweden, Iceland, Mexico legalize abortion in some special cases. Pregnancy from rape, threat to mother's health, fetal malformation, the one we have just talked about. So these are countries who legalize it. This map you can find, this is in 2015, and there is now, this is 2019, telling us which part of the world where abortion is permissible on demand, whether it is only to save the life of the mother, the one read here, only to save the life of the mother, or to preserve health, socioeconomic grounds, these areas, which are probably there. The green areas here without restriction as to reason. Whether when she wants it, she had it. This is map prepared by the World Abortion Laws. You Google it, you will find it. That was an old map, and this is a new one, and you may find another new one. So having dealt with abortion and its laws and how to do it, I'll give you a case scenario of another ethical problem you are going to meet. Dr. X is an obstetrician and gynecologist practicing in UK, United Kingdom, England. Mr. W came with his wife, who is now 8 weeks pregnant, and who would like to know the sex of the conceptus. And that is easy and possible to be shown by the methods which I have just mentioned. How should Dr. X behave? Tell him or refuse in a polite way. This is a case is happening almost for obstetricians anywhere in the world every day. The couple would like to know the sex of the baby, and they will give you their reasons. In the Sudan, we tell them. But I put it here to illustrate that in some cultures, they have preference for the sex of the newborn, whether it is a boy or a girl. And accordingly, they will decide. Example here, in some parts of the world, as I have said, they don't like female fetuses. They don't like female children. So they go to the doctor to tell them about the sex of the conceptus. And if it is a female, they will ask for an abortion or a termination of pregnancy. And they can have it whether in government or non-government, private, or in any other way. So you have to be very cautious. Why is the couple interested in knowing the sex of their child? Techniques for sex selection, preconception and postconception. There are certain methods to do it. Preconception sex selection, sperm separation, and pre-implantation genetic diagnosis. As I told you, in IVF clinics, an embryonic cell biopsy, we take a cell. From the cell, we will know the diagnosis genetically XX or XY, and accordingly, we will put it back into the uterus according to medical reasons for that. After implantation is established, and here, if Y fetal DNA can be identified in maternal blood by PCR, chorionic villus sampling, and amniocentesis or echography. So the techniques to know the sex are there. The idea to tell it or not, or the reason behind the couple want it, you have to be sure that it is not interfering with the health of the newborn because of its sex. Sex selection for non-medical purposes. For medical purposes, as I have said, agreed. Non-medical purposes. You use of sex selection to avoid sex-linked genetic disabilities is generally considered justifiable on medical grounds. To know the sex, to avoid the sex-linked genetic disabilities. That's acceptable. Majority of women are disadvantaged in enjoyment of economic, social, educational, health, and other rights. That comes an issue whereby they prefer a female baby or a male baby. Generally, women worldwide are a disadvantage. So systematic rights abuses such as selective abortion of female fetuses, female infanticide, neglect of girl children, and failure to provide either access to or support of health care for girls. So these are abuses to the female in general, from being in utero till she is a lady later on. And that should not be accepted medically or ethically. Legal approaches to sex selection from non-medical reasons vary from country and range from no specific regulation of this issue to complete prohibition and criminalization. Selection for non-medical reasons vary from one country to the other. Some accept it and they do abortion for the sex which they don't like. Others, part of the world, is restricted, is prohibited. Irrespective of the approach to non-medical sex selection, all health professionals and their society are under an obligation to advocate and promote strategies that will encourage and facilitate the achievement of gender and sex equality. So here we are dealing with gender and sex equality. Performing an abortion, you are going to affect the sex which is not wanted by that community, and then you will create many problems for them. Another case scenario, which you will see. We talked about abortion, we talked about principles, ethical principles general. We talked about abortion, we talked about sex selection. This is another issue. Mrs. Y brought by her husband to have investigations for infertility. They are married for 5 years without any pregnancy, a common problem which you will see in the clinic almost 3-4 cases per day. She performed the standard necessary investigations in the blood and X-ray, which were all within normal reference range. Decided that she should have a small operation after testing her husband's semen. Unfortunately, the husband, reluctant, he refused to have his semen being tested, and he believed that he is sure of himself, that he is fertile, and he has done it 2 years back, and it was normal. It's a common problem which they tend to see in our country. They always blame the female for infertility, and the cause could be the male. So just the case, this case will illustrate to you that if you have an infertile couple, the start of the investigation should be by the husband, because the investigation of the husband is non-invasive, while most of the investigations in the mother or in the lady are invasive, yet she is willing to do it. So if the husband refuses, you should refuse the whole case. You have to convince that the husband to be tested, and accordingly, we will proceed for all the necessary investigations, reaching up to the stage of in vitro fertilization. So as a gynecologist and obstetrician, there is an ethical framework which we have to work within it. Because we are dealing with a certain population which tend to be vulnerable. Women tend to be vulnerable because of social, cultural, and economic circumstances. That's worldwide, probably differs from one community to the other, but it's worldwide women are vulnerable and at risk. The principle of autonomy, the one we have earlier mentioned, that she is the one to make the decision for her medical care, emphasizes the important role women should play in decision-making in respect of their health care. Unfortunately, in our country, in the Sudan, we tend to depend more on the male side of the patient. She is the patient. She is the one who has to give the agreement for the tests to be done, for the operation to be done. Women should be provided with full information on available management alternatives, including risks and benefit of decision, and accordingly, there is a special need to protect patient confidentiality. We shouldn't tell others what she had. She is the one to convey it to them. The reason here, in our country and worldwide, stereotype thinking about women. Stereotyping means all women are. You think all women are, and this is the belief, which is wrong. Stereotypes have included beliefs such as that women deserve more than anything else to bear children and will willingly sacrifice any other interest of their own to motherhood. Is it true? We think it's so. Probably it is not. A graduate woman wants to carry on with her career and then later on to have her children. They will provide care to their family members. Their job is to sit at home, provide home care. They are vulnerable and incapable of reliable or consistent decision making, which is equally not true. They will be supported by men folk, breadwinners in their families. And obviously, practically now, you see a lot of women supporting the families. Educated, working in quite senior jobs, which at one time thought to be for men only. They will be subordinate to men, such as fathers, husbands, brothers, co-employees, and doctors. All these are fallacious. This stereotype thinking is false. So we have to change our mind about the way we think about women, ethically, professionally in our profession, in the social life, and in the society. Things have changed, and we have to give them the all four principles of ethics: the autonomy, beneficence, non-maleficence, and just. Another case, an 18-year-old mentally retarded girl brought by her parents seeking medical advice. She had a verbal capacity of 3 years old and a general mental capacity of 6 to 7 years old. She is 18 years old and mentally retarded. She started menstruating at the age of 15. She plays around with children of her age of both sexes. Due to her low mental faculties, her parents are worried that she may have sexual relations that may result in a pregnancy, and accordingly, they would like her to have surgical sterilization. You are the doctor to decide for that on ethical grounds. Would you do it or not? I'm just put the case here without giving you the answers of how. I will give you the options you can use. Obviously, we know the risk. If she have a pregnancy, she won't be able to look after the child. Forget about the stigmatization of the family and the rest of it. She won't be able to look after him. Somebody has to look after him. An unborn child to a mentally retarded woman, how will it go? So you better stop it altogether by doing surgical sterilization. This is one option. Other options to use reversible contraceptive methods. Sterilization is non-reversible. Reversible methods are something like injections, implants or implanon, intrauterine contraceptive devices. All these are reversible. So you have to choose whether you are going for a surgical sterilization, whether she is going for a reversible methods, whereby she may need to have a child later on, but put in mind that she is already 18 and mentally retarded. This is just a case for ethical discussion. Another problem which you will see, Mrs. S, 32 years old married woman, university graduate. She had 3 pregnancies before, 3 normal vaginal deliveries for 2 boys and 1 girl. She is now 34 weeks pregnant, and the pregnancy is progressing normally. She read in the internet that cesarean section is far much better for her case and wanted to be done for her in this pregnancy. So she had 3 normal vaginal deliveries. Being an educated lady, went through, checked the literature or the internet or hear from her friends that cesarean section could be done, good for her, and she asked for that. Asked the doctor, would you do it or not? The obstetrician here refuses to do cesarean section or refused to do cesarean section on ethical grounds. Why? Surgical intervention. Cesarean section is a surgical intervention with potential hazards for both mother and child. Though now it's becoming fairly safe operation, cesarean section, yet it is a surgical intervention. It uses more healthcare resources than normal vaginal delivery. There is an increasing rate of cesarean delivery for medical, legal, psychological, social, and financial contributing factors. Increasing requests for delivery by cesarean section without medical indication. So this is a situation which is starting to happen in our country. Worldwide, it is already there. We know some parts of the world, almost 80% of deliveries were done by cesarean section, especially in the private sector, whereby we know vaginal delivery is safer to the mother, to the child, and using less facilities for the government. So, as a physician, he said no, the obstetrician, because his duties to do nothing that may harm their patients, non-maleficence. You may harm the patient if you do cesarean section. Your duty also just to allocate healthcare resources wisely to procedures and treatments for which there is clear evidence of a net benefit of health. Societal duty. So this is just ethically you distribute what is available for what it needs and what is it for. Physicians are not obligated to perform an intervention for which there is no medical advantage. That's clear. Still non-maleficence. Normal vaginal delivery is safer in the short and long term for both mother and child. Surgery on the uterus has implications for later pregnancies and deliveries. So for those reasons, the concerned obstetrician was reluctant or refusing to do cesarean section on demand. And we hope that will continue not to be done, because if there is a medical indication, yes, by all means, go ahead and do it. If no medical indication, don't. Thank you for your attention, and we stop here on the first part of our talk in obstetrics and the ethical issues for it. So we'll stop here.